Okay, thank you very much. Good morning to all of you.
Good morning.
We thank God for giving us another privilege to meet for this program. I'm very sorry where I am. I'm in different place altogether, and I'm operating from different office, and there is a lot of noise. I'm trying to minimize it, so kindly bear with me. Thank you very much, and may God bless you. This morning, the opening section of the conference is captioned Classic View of HIV/AIDS in Africa, focusing and refocusing. So what were we focusing on, and what are we going to focus on once again? This is what, by the grace of God, we are here to go through. What has happened and what is happening? What were you doing right? And we've neglected them, and what is expected of us. This is what we will be looking at. Therefore, as we all know, when you say HIV, what comes into the mind? HIV, it is an abbreviation of human immunodeficiency virus. And as we all know, it attacks the body immune system. And untreated HIV will surely lead to AIDS, that is acquired immunodeficiency syndrome. And it has been published, and it is true. We can substantiate that as we speak now, there is no effective treatment or effective cure for it. So when you get it, it means you'll be living with it forever. Okay. HIV/AIDS cannot be cured. Therefore, we need not to confuse ourselves that it can be cured medically. Those tested positive will have the virus for the rest of their lives. However, with access to effective HIV prevention,
Non, pour l'instant, dès que le virus pénètre dans le corps,
HIV infection has become a manageable chronic health condition. People to live with the virus for the rest of their life, healthy, and also they're able to go about their duties. So we should pay attention on the management, the treatment, Some scientists believe that HIV originally came from a virus, particularly from chimpanzees in West Africa during 1930s, which was transmitted to humans through the transfer of a contaminated blood when these animals were hunted as meat. Over the years, the virus spread from Africa to other parts of the world. So some scientists are of the view that the virus came from a chimpanzee because a hunter went to the bush and he killed this chimpanzee. And when he came home and they ate the meat, as a result, they were infected from the contaminated blood of this chimpanzee. And as a result, it spread beyond Africa. Beyond Africa. And the question is, if it was as a result of a chimpanzee, now do you still find the virus from other chimpanzees? Some scientists are also asking these questions. Another school of thought also says that HIV was a biological warfare. They were manufactured and they were injected. They injected people with the virus. And as a result, it spread from Africa to other parts of the world. It was not until the early 1980s when rare types of pneumonia, cancers, and other illnesses were being reported to doctors that the world became aware of HIV and AIDS. So it started long ago, but around this period, patients or people started experiencing some conditions. And as a result, it drew the attention of our clinicians, our doctors, our experts to this, that, oh, now it is a problem. Let us focus once again on the historical antecedent of the condition. HIV was first identified as a medical condition in Africa in the early 1980s. It was later became an epidemic after its discovery. So around the year around 1980s, here in Africa, we were able to ascertain that it is a problem which we should be able to give attention to it. Throughout history, HIV has devastated the continent of Africa more than any other continent in the world, with a significant number of AIDS infections, disabilities, and death. Underline these three things for us. AIDS infections, Africa is always number one. Disabilities, Africa is always number one. HIV deaths, Africa is always number one. Now, we should be able to ask ourselves, why is it that Africa is always number one when it comes to HIV infections? Why is it that Africa is always number one when it comes to HIV disabilities? Why is it that Africa is always number one when it comes to HIV deaths? In the year 2003, more than 3 million people died from HIV/AIDS. And Africa became the home of 67% of the global HIV cases. So always the problem is on Africa. Now, I want us to look at the problem, which will help us to address them. HIV/AIDS infection in Africa are alarming, with thousands of new cases and deaths daily. On the continent of Africa, every day, a lot of people are being infected with HIV. And also, a lot of people are dying as a result of HIV/AIDS. Another problem is that babies are born with a virus from infected parents. The third problem is that a reasonable number of HIV/AIDS victims do not have access to antiretroviral drugs or treatment or therapy. The fourth problem is that most of the Africans who are active in sex are not aware of their HIV status, and they engage frequently in unsafe sexual intercourse. So it is a problem. It is a serious problem. It is a problem which we need to address. These are some of the problems in our hospitals, in our churches, in our families, in our communities. We should be able to address. Let us look at this map of Africa colored according to the percentage of adults between 15 and 49 years population with HIV. So look at your country. I'm from Ghana. With Ghana, when you look at Ghana, Ghana falls under the second category. Now, WHO is saying that in Ghana, now they can tell us that the percentage is between 2 to 5%. But when I looked into the literature, it gave me something different. And it will also interest you to know that this projection is correct, because at times, most of us We are not even aware, and then the data at our disposal is also not sufficient. When you look at Botswana, South Africa, and the southern part of Africa, it tells you Zimbabwe, Lesotho, and the other parts of Southern Africa. And even Middle Belt is also a problem. These are some of the things we should be able to draw the attention of our people to, so that we will be able to solve the problems together. Let us be specific here. South Africa, they are saying that in the year 2022, 7,600,000 people were being recorded as those having the condition in the country. Mozambique, 2.4 million. Uganda, 1.4 million. Zambia, 1.4 million. Kenya, 1.4 million. Zimbabwe, 1.3 million. Malawi, 1 million. Ethiopia, 610,000. Democratic Republic of Congo, 490,000. Cameroon, 480,000. Botswana, 380,000. Lesotho, and 270,000, and in that order. So let us scale ourselves down to look at these 4 unique countries. South Africa, 7 million plus. Malawi, 1 million plus. Cameroon, 480,000. Botswana, 340. Friends, it tells us that we are in crisis. The continent is in crisis. We are in crisis of hunger. And at the same time, HIV is killing and taking the young ones. We are being infected with HIV virus at an alarming rate. We are in crisis. We are in crisis as a continent. Most of our people even don't have potable water to drink. And at the same time, HIV is killing our people. Therefore, we are in crisis. Look at how our brothers and sisters are struggling even for water. Look at crucibles they are going through. We are in crisis. Crisis of war in Central African Republic. Everywhere as a continent, even look at the houses we live, in which we live. We are in crisis. HIV is killing us, and also we are dying from other pains which we battle with in life. A lot of children are being infected with HIV/AIDS. And Africa has the highest number of HIV cases among our children throughout the world. It tells us that we are in crisis. In fact, let us be specific. In the year 2002, looking into the prevalence of HIV/AIDS for those of us in Ghana, Greater Accra region reported 2.1%, Western region 2.2%, Broward region 1.8%, Central and Volta regions also gave or reported 1.7%. It tells you that it is a problem. As published on 5th August 2023, approximately 354,926 people were living with HIV/AIDS in Ghana. And from these statistics, when we scale it down, 115,235 were males, and 239,692 were females. The country HIV prevalence rate stands at 1.8 million. Okay, so it is a problem. Another study said it is between 2 and 5%, and this is also saying that it is 1.8 million. When it fuse the two together, it tells you that HIV/AIDS is a serious problem in Ghana. Therefore, we need to give much attention to it. Let us come to Nigeria. In the year 2001, 1.9 million people in Nigeria lived with HIV. Women were the most affected group. Children up to the age of 14 years with HIV were equal to 170,000. And that was as far as 2001. And when our doctors, the researchers, our biostatisticians, when they tell you that the prevalence or it is 1.9 million, the implication is that it is even times 3, because these were the numbers you were able to have access to. What about those who didn't go to hospital to be tested? And they are moving, and we are sleeping and moving, and then doing a lot of things with them when it comes to transmission. So it is a problem. In Cameroon, 480,238 people were living with HIV in the year 2022, and with 9,905 new cases in that year. This was reported by World Health Organization. Gabon, in the year 2021, it was a huge problem. The prevalence in Gabon was 3%, and it fell gradually from 5.4 in 2002, 3% in 2001. And if it is 3%, it tells you that it is a problem. I'm so excited that it fell from 5.4 to 3%. And as they keep on educating people, I strongly believe it will come down a bit for us. So we should be able to understand that it is a big problem. Now, whilst focusing on Africa, more than 1 million adults and children die every year from HIV/AIDS in Africa. Since the epidemic of HIV/AIDS, more than 75 million people have contracted the illness, and over 36 million have died from HIV/AIDS-related causes. And 71% of HIV/AIDS-related deaths in the year 2011 were people living in Africa. Why Africa? Antiretroviral drugs treatment declined. It should decrease the number of HIV-related deaths, and also delay the progression to allow people to live relatively healthy and normal lives. Due to an insufficient supply of antiretroviral drugs, few HIV/AIDS patients have access to the drug. This is the problem we are battling with in Africa. In some countries, they don't even have access. And even when there is a supply, they are not adequate. Some people will go to hospital for the medication or for treatment. Their facilities will be telling them, we don't have medication. And they have to go home. Some 6 months, some even a year. And then their life will be deteriorating. This is what we are going through on the continent of Africa. This makes it so serious. Yes, there is a treatment. There is a medication. You can take it. If God will give you 100 years, by the grace of God, you can live to the fullness of this 100 years. But the problem is that, you may not be able to have access to the medication all the time. With this background, why don't you prevent the disease? With this background, why don't we keep on sounding the trumpet? With this background, why shouldn't we keep on educating our families, our church members, our schools, places we find ourselves? That please, those of you who are of the strongest opinion that yes, there is a medication for me, I will take it, I will do well. So even the HIV, even if I even have it, there is a medication. I'm telling you, people are dying because they are not having access to the medication. And also, among those who have the medication, some of them also refuse to comply with the regimen. The average life expectancy in some countries in sub-Saharan Africa is 49 and 50.4 years respectively due to HIV. People are dying. And the HIV/AIDS epidemic has drastically slowed the economic growth and social development in Africa. Most of its victims are unable to work or receive education increasing the poverty level in Africa. Friends, as a result of the condition, some of our people cannot even work. They don't even have access to the medication. They cannot even study. They don't have access to the medication. They can't even affiliate themselves to other professions so that they can earn bread for their families. And they'll be lying on their beds, dying as a result of having no access to the medication. It is a problem which we should be able to address. We will continue focusing on Africa. On the continent of Africa, contraceptive use of condom has doubled in the recent years. However, the method is void when couples are hoping to conceive or have already engaged with infected persons. I have HIV/AIDS. I want to conceive. Yes, we know medically that those who take their medications, there is a possibility they have higher percentage of even conceiving without even infecting the child, the baby. But now, there is no medication. There is no medication. And even among those who receive, some of them even receive it in sporadic. You get some now, but next month or next 2 months, the person may not even find. There are some countries in Africa where the accessibility to the medication is so easy, but there are some places also where they find it very, very, very difficult to have access to the medication. I want to conceive. I need a baby, and I can't keep on using condom because I need a baby. And once you need a baby, you also don't have the drugs as a positive patient. So it becomes a problem on the continent. You keep on focusing on Africa. In some countries in Africa, condoms are expensive due to high tariffs on its import duties, increasing the levels of unsafe sex. Some countries in Africa have placed taxes on condom. And also it becomes a big problem for the users to have access to it, because their respective countries have placed huge taxes on it. So someone who wants to engage, who is positive and who wants to engage in sex, may not find it easy to have access to it. Although we keep on promoting that abstinence is always the best, or stick to your partner. But assuming the person will not comply, assuming the person will not take it, what should the person do? We should be able to advise the person to go for condom. But the condoms are not accessible. So what should we do? We should be able to raise our voices wherever we find ourselves, that the lawmakers will be able to have health as their top priority. We will keep on focusing on Africa. A pregnant woman without proper drugs has a 20 to 45% chance of infecting their infant from pregnancy. So in our churches, in our communities, let us tell our people that our mothers or those in reproductive age who are not taking their medications and are positive, they have 20 to 45% chance of infecting their babies, meaning that there is a high possibility, even if the percentage is even 0.5, it is really significant when it comes to life. And now it is between 20 to 45%. And 59% of HIV positive people in Africa are women. Majority of children diagnosed with HIV get the virus from their mothers. So mother, if you're not taking the medication, there's a likelihood to infect your baby. Therefore, as pastors, as health ministry directors, as medical directors, as management of our various hospitals, wherever we seize opportunity, we should be able to sound, to blow the trumpet that people should be able to take away. They should take their medications. It is very, very important. In most of our HIV/AIDS treatment clinics, you find that even our patients, our clients who come to the clinic, most of them don't comply. So we should be able to encourage them. Let us look at timelines and series of events when it comes to HIV, and to help us to drive our message home. In the year 1981, there was a discovery of HIV/AIDS. In the year 1982, the first case of HIV or AIDS was ascertained. Canada reported the first case of AIDS in the March of 1982. Okay, and it was established that the infections can occur through sexual contact. At that time, in the year 1982, in Canada, our scientists were able to finalize that through sexual contact, HIV can spread. In 1983, they were also able to ascertain that women can be infected. Women can be infected with AIDS through heterosexual their partners, meaning that woman couples, if one of them is even positive, the man who is positive can infect the wife, and the wife who is positive can also infect the husband. In 1985, the first conference on AIDS was organized. In fact, the first international conference was held in Georgia, US, and the first Canadian conference was held in Montreal. So in the year 1985, they held the first HIV/AIDS Congress, blowing the trumpet all over the world. In the year 1986, they were also able to ascertain that the virus can transmit from mother to child. And in the year 1987, by the grace of God, antiretroviral drug was also approved by FDA, US. In the year 1988, World AIDS Day, the first World AIDS Day was organized, and it was held on 1st December 1988. In the year 1980, people living with AIDS slogan also came out. 8 to 10 million people were living with AIDS at that time. So we were promoting, encouraging, helping people to ascertain, to accept that, yes, people can live with HIV. And those who have HIV, it doesn't mean they are sinners. No, we need not to discriminate against them. In the year 1991, there was a symbol of AIDS awareness, and then this symbol came out. The year 1999, then there was a troubling statistics who announced that HIV is the 4th cause of death worldwide and the #1 killer in Africa. In the year 1999, World Health Organization came out. It is #1 in Africa, #1 in the world, and then it is a problem which all of us, we should be able to address. My able listeners, I am here this morning to draw your attention to one fact. Africa is bleeding. Africa is a bleeding continent. The land of peace, health, food, with all kinds of minerals, is bleeding with HIV. We are bleeding with poverty. We are bleeding with weak policies and governance towards prevention of AIDS. Now, looking at the prevalence of HIV in Africa, I'm telling you, HIV testing should be compulsory, because we know that when a prevalence of the disease is more than 1% in any country, the general testing, there should be a general testing, and it should be compulsory. That when you go to hospital, one of the things we should be able to do is to screen for the presence of the disease, so that if you have, we'll be able to help you. We should be able to help our people to understand that the continent is bleeding. Therefore, we need measures of this nature. Sexual transmitted diseases and HIV, they move alongside. At a point in time, the continent recorded 3.5 million cases of syphilis and 15 million cases of chlamydia and 60 million cases of gonorrhea, and in that order. In fact, WHO Regional Director for Africa, who is in charge of HIV, Dr. Mioti, gave a speech, and I would like to share this speech with you on World AIDS Day, the year 2022. This is what he said. This World AIDS Day, I urge government and partners to close the inequality gaps towards ending AIDS by focusing on the populations being left behind. We have people who have tested positive. And what about the population left behind? Without placing much emphasis and attention, coming out with policies to protect them. A day is coming, all of us in the continent will be HIV positive. Governments should have policies to protect populations left behind. We need to put people at the center of this response by organizing services around people's needs and promoting integrated, patient-centered approaches that are strongly linked with primary healthcare services. All member states should expand and sustain access to essential HIV prevention and treatment services. Every country in the world should have budget allocation, resources for this. To continue with the following, we must ensure that everyone, everywhere, has equal access to HIV prevention, treatment, testing, treatment, and care. Prevention, testing, treatment, and care. These four components, we should be able to see to it that everywhere, everyone, and everywhere, people have equal access to prevention, testing, treatment, and care. Finally, listen to this profound speech from our doctor. I call on the community leaders to reach out and assist their populations with access to HIV services when needed. The leaders and all communities should combat stigma and discrimination by ensuring that everyone feels safe to access HIV/AIDS services. What a profound speech. Our leaders, our church elders, our doctors, our pastors, our political leaders, in our hospitals, in our communities, we should be able to combat stigma and discrimination by ensuring that everyone feels safe to access HIV services. I quite remember about some years past when I and my wife, we were going to have our wedding, and the counselor, Pastor Dr. Ajeba, counseled us that you should be able to go for HIV screening. So when I went to the hospital, I will not mention the name of this hospital or the facility. I was asked, why are you here? What do you want us to do? And I said, please, I'm going to marry and I'm coming to do HIV screening. And then the one who was attending to me looked at me from my feet up to my head. So with this, how will the person or how will people be attracted? Anyway, that was over 20 years ago. If this is happening in our facilities, how will people be motivated to come? And I'm thankful to God that such behaviors will never happen in any Adventist institution. So we should help our people to feel comfortable, to feel happy to come for the services. In fact, at least here in Ghana, I know one of our facilities, when you go there and you see how those who are coming for these services, how happy they are, it tells you that the leadership of this facility is doing well. So please, it is something we should be able to take into consideration. Now, looking at the classic view, unique approach towards the prevention of HIV, what are we here to promote? One, we are drawing our attention to some of the elements from the wonderful presentation of Dr. who is in charge of ACE for Africa. Equal access to HIV prevention, testing, treatment, and care. The leaders and all communities should combat stigmatization and discrimination, ensuring that everyone feels safe to access HIV services. And also, every patient to take the ART. Teachers are to educate students about HIV/AIDS. Now we've relaxed. I can't remember when I was in junior high school, our teachers, when they come to class, they will be educating us about HIV/AIDS. Parents are to have family HIV/AIDS days at least once in a month, whereby families will be able to educate their children about HIV/AIDS. In fact, the last 3 points is something we added so that it will help us to drive home the message God has placed on our hearts. Every patient should take the ART, the medication. Teachers are to educate students about HIV in our schools, in our churches, elders, pastors. When we mount puppet, at least let us take 5 minutes of our time helping people to ascertain that HIV/AIDS is still a problem, killing people indiscriminately on the continent of Africa. And as parents, every month, we should be able to have at least monthly HIV days, AIDS days, whereby we will sit our children together, then we educate them on HIV/AIDS. The problem of Africans can be solved by we, the Africans. We don't need white men to come and tell us that we should take our medication. We don't need white men to come and tell us that we should go and test. Therefore, once God has given us this capacity, this mandate, let us start gathering the axe. Let us make application of the tools, the logistics around us. HIV/AIDS impact people's healthcare. In South Africa, 80% of patients hospitalized in public hospitals are HIV positive. Friends, it is a problem. About 3 out of 4 adults or 9 out of 10 don't have access to the treatment. And it's a problem for us. Recent analysis is just a minute, please, just a minute. Thank you very much. A recent analysis showed ART coverage in adults, pregnant women, and children is significantly lower in countries with lower prevalence, leading to the potential spread of the disease. Will that health and economic impact on the continent? So in Africa, we should have this in mind. Who can cure HIV/AIDS? Medically, it is not curable. Though we can treat the symptoms, we can go for treatment, but we cannot cure. Reading from Bible gives me hope as a Christian. The word of God gives me hope. Jesus went about Galilee, teaching in their synagogues, proclaiming the good news of the kingdom, and healing every disease and sickness among the people. Jesus was healing every disease and sickness among the people. News about him spread all about Syria, and people brought to him all who were ill with various diseases, those suffering severe pain, the demon possessed, those having seizures and paralyzed, and he healed them. So God is able to heal every kind of disease. Large crowd from Galilee and other places, even up to Judea, the region, came all over from Jordan following Jesus, because they saw that he is a man with power to cure diseases. Yes, Jesus can cure every disease, including HIV. But even if you have this hope, if you have this belief, it shouldn't deter you from not to take the medication. Take the medication. Whilst you keep on seeking the Lord in prayer. James chapter 5 verse 13 to 16 said, is any among you in trouble? Let them pray. Is any among you sick? Let them call on the elders of the church to pray over them and anoint them with oil in the name of the Lord. And the prayer offered make the sick person well. The Lord will raise them up. If they have sinned, they will be forgiven. Therefore, confess your sins to each other and pray for each other so that you may be healed. The prayer of a righteous person is powerful and effective. So Jesus is saying that God is able to heal every disease, even including HIV. Once again, if you have this hope, if you have this faith, it doesn't deter you or prevent you from taking your medications. Keep on taking medications, keep on praying, and keep on protecting yourself from being infected, your children, your church members, and let us keep on seeking the Lord in prayer. Jesus is the greatest physician. Let the church organize prayers meeting for those with all kinds of diseases, including HIV/AIDS, including cancers, including stroke, and our God is able to heal them all. Jesus is able to do everything. Let us keep on having faith in our God. If you have HIV, it doesn't mean that is the end of your life.
Yes, sir.
If you have HIV, it doesn't mean that God has rejected you. If you have HIV, it doesn't mean you are a sinner. If you have HIV, it doesn't mean you are useless. Jesus still loves you. Let me tell you this. I am struggling with maybe heart disease. And Janet is struggling with diabetes. And Grace is struggling with cancer. And Kobna is struggling with HIV. What makes the difference? We are all sick. We all need Jesus. Friends, HIV, back to HIV. The rate at which HIV is spreading in the continent of Africa is questionable. We should go back to our roots, where we were campaigning, educating, sounding the trumpet, helping people to appreciate, to abstain from unsafe sexual practices, living with our partners. Friends, if you can do this, and those who are positive, if they'll continue taking their medications, the spread of the infection will reduce. Hello, please, someone is disturbing us. There is a hope for those even dying from HIV. Even if you don't have access to the medications and you're even dying, you should die with the hope of the resurrection morning. John 11, verse 25. Jesus told her, I am the resurrection and the life. Whosoever believes in me, even though he dies, will live. If you believe in Jesus and you die, by the grace of God, when Jesus comes, Jesus will bring you back to life, even including those living with HIV/AIDS. And everyone who lives and believes in me will never die, meaning that on the day of reckoning, I will bring them back and then I'll take them home for them to live with me forever and ever. There is hope for people living with HIV. And also, there is hope for those who don't have. We should be able to prevent ourselves and protect ourselves in order not to have the condition. Thank you, and may God bless you.
Thank you, Doctor.
Thank you. The floor is open.
Thank you, Doctor.
If there is a question.
Yeah, there's a question, Pastor, if I'm permitted to ask or
Yes,
speak.
sir. Question or contribution? Yes, sir.
Thank you. Okay, thank you, Pastor, for the nice presentation. My name is Kwaku Badu from Ghana, Health Promotion Officer. I work at Ghana Health Service.
Wonderful.
And I think, Pastor, you have done a good job. But my first question has to do with religion and health. Religion and health, how do we address this issue? Maybe the person will visit the health facility to test for HIV/AIDS. If the person gets tested and is positive, the person may be in the denial stage. He or she will go to the pastor, and the pastor also related to spiritual. Now, in Africans, we tend to believe our pastors or our religion than the health people, I should say. Most of these people who are HIV positive tend to relate the condition to be a spiritual sort of things. With that regard, how do we address it? How do we, as we are sounding the trumpet, how can we convince people that HIV is not a spiritual disease or condition? My second question too has to do with the psychological stress or trauma. Though I don't have any literature or data or evidence to back my question, but I believe that most of these people also die as a result of psychological trauma or stress. So how do you also address that issue? If you are with a colleague or a friend who is an HIV patient, how do you try to break that gap or bridge so that they will also feel that, yeah, though he or she is a HIV patient, but is part of the community, so that the person will feel free to mingle with others. In the presentation, Pastor made mention of the testing should be made compulsory. Pastor, please, looking at the medical legal issues too, I think the person has to accept before he or she gets tested. So if we try to, let me say, to do the testing by using force or compulsory wise, are we not against the medical legal issue?
Thank you very much. Thank you very much. You've asked 3 powerful questions. Let me see if I remember all of them. I'll start from the bottom. Making the tests universal doesn't mean that it should be compulsory, but it should be accessible, it should be available, and people should be encouraged. And when we encourage them and they will come for it, fine, it will help us. So that is it. And wherever a disease, the prevalence of a disease is more than 1%, from the angle of public health, we advise that there should be a general testing. And even with this, if the people will not go for it, you cannot force them. But if people have access to it, definitely significant proportion of the people may be willing to come in for the testing to know their status. So you are right, we cannot make it false. That is it. I've seen the hand of Doctor. Doctor, do you want to speak to it?
Yes, sir. Good morning. Just a comment on that one. Yes, sometimes maybe we have to be careful on the words that we choose between making the test compulsory and making it necessary. And the reason why I'm saying that is the speaker is right about medical legal and minding people's rights. But then at the same time, you are right, doctor, to talk about the public health rights, because it is said your rights end at where my rights begin. So there's always a challenge of balancing individual rights and community rights. That is why we talk about issues of percentage to say if a disease reaches a certain level where it is a threat for the general community, then it becomes necessary for the sake of the community. Let me just share very briefly to say, by the way, I come from Botswana, and there was a time that Botswana, while our numbers of people HIV is low, there was a time where our prevalence was the highest in the world. And so our government made the decision that it is medically, whenever it is medically indicated, the HIV test will be obligatory against on all medical legal standards. Why I'm choosing the words of medical legal standards is that if somebody comes in and is showing symptoms of one disease or another, most of the time, the person who is suffering does not actually know all the symptoms that can be shown. But the clinician has an ability to realize that this person looks like they could have diabetes. They could be saying, I'm running all the time to the toilet. I don't know what is wrong. The doctor doesn't usually ask them, should I test you for diabetes? But they talk to them and say, okay, I'm going to run a few blood tests to see what might be the problem. And having found out what the problem is, they will come back to the person. Now, the question that we had to ask in our country was that if somebody is coming and they're having HIV symptoms and everything else, why is it that now we have to start asking them, can I test you for this? Whilst they come in and they seem like they have asthma and they don't even know what asthma means, or they seem like they have gonorrhea and they don't know what gonorrhea is, we test them. So it was taken in our case under the context of clinical indication. When a patient comes in and there's clinical indication, the doctors then were given the right to do what was medically necessary. The medical legal issue was then in telling the person that because of your condition, we tested you for a number of diseases, including HIV and AIDS. Would you like us to tell you the results or not? Because we recognize that when you live with that information, now it is your burden. So most people would accept, but if you do not want to know the results, you would not then know the results. But then again, that was done from a political legal perspective. Thank you.
Thank you very much. That was a political health perspective. So it's a good move for our people in the Botswana, and I know it helped them a lot with this. So it is a country specific. It depends. Thank you very much, Prof. Dog. May God bless you. So speaking to the second question or the first question, the relationship between science and religion, is that correct? Okay.
Yeah, science or health and the religion, where people attribute the disease as a spiritual. Yeah.
Yes. Thank you very much. Yes, please talk. Doc, talk.
Yes, it's me. I wanted to contribute to the religion and then the health wise.
Okay.
I've been to HIV department about 6 years, so I've worked with them. And what my brother is saying is it's a major problem when it comes to Ghana, especially. I don't know other African regions, but especially in Ghana, it's a problem because people think that HIV/AIDS is something that is spiritually related. So when you have HIV, it means they've given you injection in your dream. So that is how it came about. So when they come, most of them refuse to take their medication because their pastors or their prophetess say that it is an injection that they have given them spiritually. But that's the reason why, by the grace of God, Ghana, we have Model of Hope, and then we have mentor mothers, those who will encourage them to be of help to them. Sometimes when they come, what we do to them is, what usually I do to them or tell them is that the pastor or the prophetess who is telling you not to take your medication, some of them were here to take their medication. And by the grace of God, some of them have attained targets not detected. And they were happy leaving this place. So if you think that they are telling you not to take it, please, they are coming here for the medication. So they are deceiving you. There was a case that when at around 2018, we got short of some of our medications. And a patient went to see those one-man pastors for counseling. And then the person told, the patient told the pastor that I have this condition and I've been given the medication. What the pastor told the patient was, go and bring all the medication to me so that I will pray for you. And then the person also not knowing brought all her medications to the pastor. And then the pastor took it because the pastor was even in short of the medication and he needs it. So he took the medication and then prayed for the patient to go. The patient's condition got very worse and then the person was brought to the hospital. So we give them evidence base of what is happening underground. So if you don't know and you think that it is spiritually given, then why is it that the person spiritually they did not inject you diabetes and hypertension, but they gave you HIV instead? So if you believe that hypertension is not spiritually given, diabetes is not spiritually given, then HIV too is not spiritually. It is physical, so we have to treat it that way. Thank you.
Thank you very much. May God bless you. Well said. Very brilliant submission. Let me add, Abigail, I'll come to you. Let me add this. Please, whenever science is not in conflict, the findings of scientists or science is not in conflict with the Bible, we accept it. We believe that everything must be evidence-based, scientifically proven. If it is not in conflict with the word of God, we take it. So we don't, some Adventists, it is not our practice to tell our people that when you are sick, don't take your medication. Come and let us pray for you. God will heal you. It is a spiritual disease. You were injected with HIV virus in a dream. Please, we don't believe in that. So you also shouldn't preach and you shouldn't accept some of these things in our facilities. And we should be able to help our people to understand that they are all for us. It is not true. It is a way by which the devil is using to frustrate them so that they will die prematurely. Thank you very much. Yes, sir, Abigail.
Thank you for a nice presentation. My contribution to add to what the doctor said was, looking at Ghana now, is almost, when you take the percentage, about 90 or 85% of pregnant women or childbearing age now know their status, because it has become part of the routine labs. The moment the person gets pregnant, it's part of the labs that is done. So you counsel, you take the person through the counseling process, you do it, and when the person is tested positive, you start with the ART drugs. So it's a good initiative. And as doctor said, our clinicians and the physician, when we are seeing people based on their presentation, signs and symptoms, we can take that as an advantage to do the testing for them. And also with the religious and this, I think the education, now we've achieved something, and we should continue with the education with the religious leaders, community leaders, traditional leaders. All of them are involved. If they get the education and how we go about it, I think it's a gradual process. We will one day get there. So we should make the education a point that it reaches everyone, and I think this will help us with this information. Thank you.
Hello? Are we still there? It seems to be quiet on this side.
Same here.
Yes, just here. Hello. Hello.
Hello.
Yeah, are we still here?
Yes, we are here. We are here.
Oh yeah, Dr.
Yes,
Paul. Are we still here?
Okay, Doug. My own is suggestion. Hello.
Okay. Yes, sir, please. Can you talk?
Yes, my name is Digabel. I'm talking from Rivers Conference. So I've been hearing what you told us about HIV and AIDS. All is correct. But 2 years ago, I was working in a hospital in River State, Bori. So one antenatal patient, very smart girl, one lady came to our hospital. The lady is so beautiful and in fact, but haven't we run the test? We got antibody antigen reaction test. Because when antenatal came to hospital, the first thing they do is to run a antibody antigen reaction test, the HB of the person, the PCV of the person, the HIV status, and some other tests such as fasting blood sugar, random blood sugar, full blood counts, and all other things to know the present situation of the person, if the person primigravida and all those things. But when we run those tests, we notice that that lady have HIV, which is under 20. Just 20 years old, the 20 years old lady have HIV. So now they place this lady on the herbs, anti-retroviral therapy drugs. So after when the first drugs finished, we noticed that we got an information that the lady said she was going to spread the HIV, that she will not take it alone. So now, what I want to suggest is that because in our church, I don't think we have been taking health and this health of a team so serious. So this should be from our headquarters. You people should mobilize our leaders so that, because where I was working, it happens to be that the chief medical director there is a Deeper Life member. Sometimes he do organize a program and check and organize and do free checkup for their member. Just HIV free checkup. He will buy the street, the HIV test street. We have determined unit gold combo, many, but the most important one, the one that give accurate result is determined and unit gold. So he buy this test strip and they check the church member for health sensitization. So we too can do that. But let it be that the directive should come from our headquarters so that they will implement it. Because if people do not support, they should not announce it. Maybe they will just look it as just meowing. They should just forget about that one. But if you implement that one, today so date like this, they should do free sensitization and test for all our members. I believe the church have money that they can raise it and buy this strip and do the free test, because I believe that most of our churches they have medical personnel that can hand over such kind of things like this. And after seminar, they will now do the free test. So that is
Thank you
what
very
I
much.
have.
My brother, thank you very, 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 very much. It is a brilliant submission. I know Dr. Sikwa will be touching some of these things in her presentation. So thank you for it. Is a good counsel. It is a something we should be able to do. And in some of our fields, it is what they are doing. So all of us, I think we can do. Thank you very, very, very much for drawing our attention to this. It is for this reason. Thank you, Doc. It is for this reason we are here this morning, attending this seminar. Thank you very much. Ladies and gentlemen, by the grace of God, I would like to introduce the next speaker to you. The next speaker, she's a very simple person, down to earth. She's from Botswana, and she was chosen by the General Conference of the Seventh-day Adventist Church to be the coordinator for HIV/AIDS programs within the 3 divisions in Africa. I'm happy to introduce to you Dr. Banguato Sikwa. Doctor has served as she's a medical practitioner, medical doctor, and at the same time, she has worked with WHO. This morning, Dr. Sikwa will take us through the second presentation. Doc, you are welcome. Hello, doctor.
Yes.
Yes. I'm done with the introduction, please. You can take it from here.
Yes, I've hello, can you see me?
No.
Yes.
No.
Yes.
I don't know how you have set it up, but
Oh, yes.
Oh, okay. No, that's good. Good morning, afternoon. I'm not so sure where we are. Around where I am right now is afternoon. I switched on the camera just a bit for me to greet. I hope someday to be able to visit places. May I request that others maybe can mute their mics so that there is less interference? Thank you very much. Yes, I was saying that I'm hoping someday to be able to meet you in your various places. I have worked with the church for a number of years, but then have only covered Southern Africa and East Africa. Recently, I went for the first time to West Africa when I visited the division, and it's very exciting to meet, although virtually, so many people from West Africa. So I'm looking forward to those opportunities to be able to meet with you physically. Now, as we are going to start, I'm going to share my screen. Can you see my screen?
Yes.
Okay. So.
Yes.
Yes, oui. Oui, nous voyons l'écran là. Oui.
Okay, thank you very much. I was asked to share on the topic.
Donc, voyez, dans le rôle de santé des lieux.
I'm hearing also the French translation. Is that how it's set up? Hello?
Yes, we can hear you.
We can hear
Okay.
you. Go ahead.
No, I was saying I'm having interference because I'm hearing the French translator. So as I was speaking, they were speaking. So I was struggling to go.
Oh, okay. Watara, please, can you fix this for us?
Yeah, can just fix that for me. Okay, thank you very much.
Thank you.
Yes, I was asked to talk about the transformative and restorative dynamics of Aaim. And I thought because many people may not even be aware of what Aaim is, let me just start from the beginning, touch a little bit on that. Adventist AIDS International Ministry is Aaim. That's what the word stands for. And that is the logo that we are using. On the left-hand side of the screen, you'll be having the logo for the church, which is, as we know, is owned by the church and is an intellectual property for the church. And then on the right, we have got the HIV ribbon. And thank you very much, Doc, for taking us through the history of HIV so we all understand where we are coming from. It's a very simple logo like that. So what is Aaim? Aaim is, as it says, stands for Adventist AIDS International, but then we can say that Aaim is really a response of the Adventist Church to support its members who are threatened by HIV, infected and or affected by HIV and AIDS. And you realize that from being threatened to being infected and being affected, it covers all of us. Because all of us, if you are not infected, you are probably affected because a loved one, a relative, a friend, a colleague at work, a church member is infected and they lean on you, as somebody said earlier, that there are also psychological effects of HIV. But if you are in none of those categories, you probably are threatened by virtue of being in Africa, where, as we have heard from the numbers that were being shared, the prevalence, the incidence, the death rates, they're all so high. Therefore, we all fall within that. And Aaim is a ministry of the Health Ministries Department that actually focuses on this HIV challenge that we are having. My office covers the 3 African divisions, namely your division, West Africa division, the Southern Africa Indian Ocean division, where is my division, and the East Central Africa division. And this was set up by the church because that is where HIV has been most severe. We fall under what is called the Sub-Saharan Africa. The North Africa and Middle East has hitherto not have been so hard hit by HIV, although currently we are seeing that numbers are rising. In this presentation, I won't have time to go through some of those numbers, but at later stage elsewhere, hopefully we'll be able to do that. But from some of the figures that my pastor shared, you'll notice that historically we have had very periods where it was very, very high, the HIV and the death across board. And then it has started to go down. By 2020, 2021, we are beginning to see the numbers going down of those that are infected and seeing that many people are actually on treatment, even though many places are still struggling to find the drugs. However, over the last 3-4 years, we have started to see that areas that we thought were doing very well, their incidence rate now is rising. And the incidence rate, we are talking about the infections at any given time, the new infections. So the prevalence rate, that is the total number of those infected within a given population, may be seen to be going down, as he has demonstrated with some of the areas. I think it was Cameroon from 5% to 3%. But we are seeing that when we are comparing incidence rates, infections per year, the new infections are seen to be on the rise. And we are attributing that to perhaps the silence that came about after the fatigue. Those of you who were around, whether in the health space or of age to understand what was going on, will recognize that from around the 1990s to up around the 2000, the whole world was ablaze with HIV and AIDS information. Wherever you went, you would find out there were strategies of how to prevent. Everybody was really talking. Then it came to a point after the ARVs came in and became commonplace. Excuse me. It became common for people to be able to get ARVs. We started now to slow down. So by the 2011, 2012, 2015s, you find that the information has started to go down. By the time COVID came around, we were almost very quiet about HIV, and the cry out was taken up on only COVID. And we are seeing that we seem to be losing the mileage, hence a need for a topic like what has been brought up to say, let's get the trumpet out again, because HIV is beginning to gain grounds again since the world is quiet. And we are saying, as a church, perhaps we were a little bit late playing catch up to cry out over HIV last time, but this time around, let's not be caught napping, especially since now we have got structures and systems in place. So what is the mission of Aaim? Our mission, as stated, there is to be a grace-filled ministry demonstrating the hope, love, and compassion of Jesus Christ by involving all the church levels, starting from the leadership, including our institutions, our organized congregations, up to the level of the individual believers. And what are we involving them on? HIV awareness, prevention, care, and support. So this is what Aaim does. And contextually, our vision is taking into consideration our world vision, because at this point in time, we are working with the strategy of I will go. Therefore, our current vision has been recrafted to reflect that our vision now is to respond to the world church I will go strategies by looking at the HIV/AIDS pandemic needs in accordance with Bible principles. How do we do that? We do that through education and training, prevention strategies, care for those that are infected and affected, mainstream in all other ministries, and collaboration and partnerships. And I will just touch on a few of this as we go through this presentation. But as we begin to interact more, those of you who are Aaim coordinators, we will be hopefully giving you more tools, and we pray God will help us to be able to work with you from within your context, that you may be able to gain more tools, more ideas on how you can utilize these methods contextually. We recognize as an Africa office that each country has got its own dynamics, and they've got their own politics, they've got their own environmental issues. And we know that even within the country, you have got regions and specific territories or municipalities, however they are subdivided, that will also have other issues and challenges that they need to deal with. So for that reason, I'll be giving you ideas and suggestions, recommendations at what we will call a higher level, which is more of a global Africa level. A lot of them, they're informed by what have been tried and tested in other places. But we recognize that not everything will work for everybody. And therefore, we will be looking forward to hearing what you have done in your specific place. How have you contextualized, and how have you even come up with own creative ways that are answering your specific challenges wherever you are? Now, we are talking about transformative and restorative dynamics. I'm going to go through what are the basis of those dynamics that we are trying to put on your tables. The first one Whatever it is that you are bringing up here is based on the strategy that covers from the church from 2021 to 2025. Why? Because we are an entity that is under the church. Even yourselves, those of you who are working either as a health leader at a church level, or you are at conference level, or you are at union level where you are a coordinator, the leadership of the church, the elders, the pastors, they are expecting that whatever it is that you are doing should not be deviating from where the church is trying to go. So your challenge is going to be always, how is that adding to what the church is doing? So the basis of my presentation is try and help you recognize that from the General Conference perspective, when we are looking at the strategies that the General Conference has put in, how do we contextualize those into HIV? The second basis of our operation is recognizing that Aaim is about HIV, and HIV is a global health issue. And as a global health issue, we do have global health targets, like your 2030 WHO goal to end HIV/AIDS. As a public emergency. We have got UNAIDS, which is a United Nations organ that looks after HIV, that has set targets like your 95, 95, 95. Many of you may be alive to that, to say the first 95 is going to say 95% of people that are living with HIV should know that status by 2025. And I thank you very much for the lady from, I think it was Ghana, who gave us the appreciation that at least up to about 90% of at least those that are pregnant, they know the HIV status. So those are some of the things that the world is chasing, and we are part of the world in that perspective. The second 95 is about treatment, to say 95% of all those that know they're HIV and are in need of treatment must be on treatment, because we know that ARVs have been shown to be able to control, even though they can't cure the HIV. And the last 95 is to say 95% of those that are on ARVs must be suppressed. The viral load must be suppressed, because we recognize that if the viral load is kept suppressed, then even the HIV transmission from one person to another is minimized. The diseases that are minimized, you can come to a point where somebody can almost live their life and enjoy it almost like somebody who doesn't have HIV. I'm emphasizing the word almost, because you are not cured. There are still other issues that one has to live with. So we are, the programs we are going to be talking about anchor on these two bases. Therefore, when we are saying focus and refocusing, we are saying the Aaim initiative projects and programs, they should clearly demonstrate their value add to either the WHO UNAIDS initiatives or to the General Conference I Will Go strategic plan, or both. It may not be very helpful for your community or your church if one way were to come up with extremely creative ideas that neither add to where the world is going or where the church is going. And it might be very difficult to find support from other church organizations if we are not focused on those. So I don't know how many of you have seen the Churches I Will Go strategy, but I will encourage you to go online. You can just type Seventh-day Adventist I Will Go strategy and the booklet will come up. I'm going to be taking my next few slides anchoring on that. So when we look at Aaim using the I Will Go strategy and the objectives, we noted that the I Will Go strategy has got 3 key objectives. The pillars will be the mission objectives, spiritual objectives, and leadership objectives. So the Aaim office has taken the time to look at our work as Aaim and see how we support the church to answer and address the KPIs, key performance indicators, in these objectives. The first objective that we have looked under with is mission. I've taken them the way they are written in the church document. So the thing that you are seeing as one day, it will be really number 1 objective, and I've just taken it as it is written there. Says to revive the concept of a worldwide mission and sacrifice for looking at the way of life involving not only pastors, but every church member, young and old, in the joy of witnessing for Christ and making disciples. The first key performance indicator is written as total member involvement. And we are saying, as Aaim, we have you can have initiatives that are called support groups, whereby we are able to form groups, be it at community level, at church level, in our neighborhood, of finding ways to support each other. The concept of support groups is not unique to the Adventist church, and we cannot claim to be the ones who have come up with it. But it has been found out in a number of organizations and also from the United Nations, where people suffering from certain conditions join together to support each other. And in the context of HIV and AIDS, they have been found to be very, very effective, especially for helping people to take their medication. I heard some of the stories that we've been told now of how there are people out there trying to convince people not to take medication or to go to hospital. But if one is a member of a support group, there is an opportunity for one to be able to join with others, some who have been living with HIV for a longer time and are actually able to say to you, you know what, I was there at one point not wanting to take medication, but now here I am. And it has also been found out that when people share a common cause, it won't be long before they want to know more about each other. And us being Adventists, within the support groups in other countries, we have found out where support groups are actually able to begin to pray with other people and then introduce them to Jesus Christ, the one who ultimately can heal a lot. He may not be able or may not be seen as having cured somebody of the HIV, but we do know that, as somebody pointed out earlier, there are a lot of emotional issues, there are a lot of mental issues, there are a lot of social issues that are accompanied with living with HIV. And those ones, even before Jesus comes back again, we can still deal with within the support group. So total member involvement, our answer to that as Aaim is support groups and working with support groups. And we are encouraging you that you shouldn't be putting support groups that are, say, this is an HIV support group. Let it be a support group so that those who are infected or affected can come in. Somebody may want to be a member of a support group because they want to support their loved one who is struggling. And there are many ways that you can put that together. We are looking also at key performance indicator 1.5, which states collaborate with children, ministries, help ministries, youth ministries, and Office of Advent Mission in producing reading material on mission for Adventist children and teenagers. We know that HIV affects children and teenagers. So we are encouraging us, why is this not doing what it's supposed to do? We are encouraging you to come up with ways of writing material that can actually be utilized as reading material for all of these communities. Then I'm moving away from the mission. We have taken only 2 on the mission objectives, and I'm moving into the spiritual growth objective. We have objective number 6. When you say 6, that means there's 1, 2, 3, 4, 5, there's more. For us as Aaim, we are focusing on just number 6. It says to increase accession, retention, reclamation, and participation of children and youth and young adults. We are saying that we want to look at key performance indicator number 6.1, which talks about a situation where we have increased church member involvement in fellowship and service, both in the church and the local community. We are saying that a lot of young people, it's a known fact that human sexual issues preoccupy the mind of a teenager and a young adult. And the sexuality issues are the reason why we have ended up at HIV and AIDS. As we know from the previous presentation, that HIV and AIDS is a sexually transmitted issue. In us staying silent, we are not addressing the needs of our young people. Instead, we address them by effecting the 7th commandment according to our church principles. When somebody has broken the 7th commandment, we end up with disfellowshipping. And we are saying that if we are going to be intentional and very strategic and creative on handling issues of human sexualities as pertaining to the young people, we may find ourselves being able to reduce issues that are related to the seventh commandment, disfellowshipping, and which is also part of attrition. Therefore, we believe that we can help the church with retention, because a lot of our children that are born in the church, later on they drop out of the church. Often than not, we find out that there were pregnancy issues, there were sexual indulgence issues, possibly out of curiosity and ignorance. And we are saying it is time that the church started talking about these things, and Aaim, you are the right place to do that. So what is the action item we are calling for here? We're asking you as leaders to come up with creative programs that address sexual issues of young people as an action from Aaim. And your work will be noted when the church is evaluating itself in terms of how much have we done on the retention of young people. Now, going on to the next one on spiritual objectives, we have taken number 5, which is strange. I should have put the slide first. Number 5, which says to disciple individuals and families into spirit-filled lives. It's got a key performance indicator number 5.5. By the way, the KPIs were put together by the General Conference. Ours is to see how we are contextualizing them within this ministry. So we have picked 5.5, which says, when this is done, we will see increased number of local churches and individuals using Hope Channel, Adventist World Radio, Adventist World magazines, and other official church publications and media. In West Africa division, I believe you have also some other publications, and you have got also your, I know you are also on Hope Channel, but then the question is, some of these things are not being utilized because there's perhaps only one department or two that is in the ministerial and maybe stewardship. And so we are saying this is a place where we as health ministries and necessarily as Aaim can come up with things for content, for production, for the media and publication. I've been working with media and publication over the last quinquennium when I was the health minister's director for SID. We produced a number of things, and one of the things that we produced were like devotion books where we were taking testimonies. We have stories that people are talking about, stories of health and hope. The stories that we have just been telling right now, just listening on this broadcast, I've heard at least 2 stories of people who have got HIV and their experience. Those people, those stories can actually be put into material that can be shared on Hope Channel, that can be put as testimonies in the churches. When we come up with those and we stand in front of people and we tell them, like the good doctor was telling us about some of those people who may have believed in witchcraft, but have then gone on to take their ARVs and gotten better. It will encourage somebody who is sitting in the corner and thinking their witch doctor is actually right, to go there and find out that I can go and get tested. We can have stories of people who were sick and did not know what they are suffering from. They went and got tested and were found to be having HIV, and now they are treated. And there are many people out there who are willing and ready to share their stories, and those stories can be encouraging. And those stories, they form the material whereby when it is measured, do we have an increased viewership of Hope Channel? We will have that. And when somebody comes in just to look at the stories, soon enough they will listen to Pastor Cheme preaching and other people. And then we'll have more people getting to find out Christ for having listened to our stories as Aaim. Another KPI on objective 5, it says 5.3, says we will see significant increase in acceptance and practice of church's distinctive beliefs. And I've underlined the ones that we as health ministries and specifically as Aaim are going after. A session on creation, the state of the dead and power of prayer over witchcraft and spiritualism, and principles of healthful living. Let me start with the state of the dead because we're just talking about it. And I've just heard from here that in Ghana, that is an issue. And I want to imagine also in Nigeria and other places. I've heard from Cameroon that also they have the problem of witchcraft or belief in witchcraft. Now, if people are believing in HIV being a witchcraft thing, the efforts that we will put in to educate people will help even our members begin to have a spirit-filled lives, begin to actually understand that these things are not coming from witchcraft. And as they begin to believe that, they will also now begin to affirm other things. This FB and the like, these are fundamental beliefs. Our fundamental belief number 26 and number 11 is under threat because of the diseases like HIV and AIDS. So if we do our job there, we will help the church begin to dispel the myths there. I've looked at the issue of creation. Creation, we believe that God created human beings, that we did not come from monkeys and other things. And if we came from as human beings reproduce other human beings. Therefore, the issue of human sexuality come into play. We know that one of the challenges with homosexuality is that if homosexual couples were to live on their own, that would be the end of the human race, from the perspective that two homosexuals did not reproduce unless they bring in somebody else. If it's just two men living on their own, there will be no child coming out. Two women living in their own, having sexual relations on their own, there will be no child coming out. Therefore, the issue of God as the creator and having given human beings the power to create, as in creating another human being, is taken away. We as Aaim and people who are tasked with the duty of talking about issues of human sexuality can help the church address issues of human sexuality, even challenges of homosexuality that our church is facing right now. Principles of healthful living, I don't need to go too much into that. I think as health ministries people, we know that it is our mandate. As you can see, I'm taking this from strategic plan. So if we are doing our bit, we will then end up achieving this indicator. A significant number of our members will begin to understand and appreciate our distinctive beliefs as Adventists. So what is the action item? Let us form support groups for the churches and communities for the different issues. Let us go out there. I didn't write that one as an action item also. Let us go out there and give lectures, give talks in our communities on these issues, because in doing so, we will be addressing this objective. Oh, now I have a problem here. I didn't put active action on that. Oh, I'm sorry about that. But we have got number 7 and 7.2. I should have put this as an action. I mean, the action coming after we have read through that. I'll correct before I share this. But the objective itself is to help youth and young people live up to the biblical standards, noticing that their body is the temple of God. And the key performance indicator is that we'll have the young people who believe that their body is the temple of the Holy Spirit, who will abstain from drinking alcohol, taking tobacco, and the use of recreational drugs and other high-risk behavior, and that they will embrace the church teachings on marriage and demonstrate sexual purity. I don't need to belabor that. We are the people that if we do our job well, can begin to teach our church members about the value of marriage and stay marriage, the value of faithfulness in marriage, the value of sexual purity. So what is our action item there? In our health expos, as somebody has already said, we are expecting that in our health expos, we should be including HIV testing. And the church indeed needs to help if there is help that is needed in buying the test kits or whatever may be needed there. We have got programs like Youth Alive, which I believe that the Health Minister's Director will help you guys to come up with that. I think Youth Alive has not been launched in Ward, but I believe that there are plans for that. But Youth Alive is a program that actually addresses issues of young people and sexuality within young people and human relations, and how they can avoid high-risk behavior and build resilience in all these things we are talking about. We deal with issues of drugs, we deal with issues of tobacco, of alcohol. We have stop smoking campaigns. You can come up with chastity clubs. All of this, the church already has material that can help you if you have got communities that you want to go into, starting with your own local church. If we do all these things, we will be helping the church to achieve this spiritual objective. And lastly, we have the leadership objective. The church is looking at us as a departments to align world church resources with strategic objectives, which is what I've been talking about. If we can align our resources rightfully, when the church comes to evaluate us as a department and you as a division, you'll be able to achieve this key performance indicator that every organization systematically reviews and aligns resources in light with the worldwide mission priorities. Now, I want to turn and talk a little bit in the next few slides about other issues that we deal with within the HIV world. The issue of co-infection and some other considerations. As we are forming programs about HIV and AIDS, let us not just blindly look at only HIV infections as in tests of HIV and people taking medications and suppression. Let's look at the issue of co-infections because they are quite huge for us in Africa. There are many co-infections, and I think Dr. Cheme talked a bit about other STIs, but I want to focus on two other co-infections also. Tuberculosis, because it's a big deal for us in health now, and the human papillomavirus, which causes cervical cancer. Starting with the other STIs, because they have already been touched on, let me just mention that we've got more than 30 different viruses and parasites that are known to be spread through sexual contact, including whether it is vaginal or anal. And it is important that as you are making your programs, you open your eyes to that. Because the reason why we are not just going to talk about HIV, but we want to talk about human sexuality and sexual behavior is because HIV does not come alone. Some of these conditions, pretty much like HIV, they are also transmissible from mother to child. They can be transmitted during pregnancy. They can be transmitted at childbirth. They can be transmitted through breastfeeding. And of these, of course, we have some that are curable, and it would be very nice if in our programs we talk about them because people can go for treatment for syphilis, gonorrhea, chlamydia, and trichomoniasis, which doctor talked about earlier when he talked about the details of the numbers. According to WHO, we've got 1 million STI transmissions daily worldwide. Every day, 1 million people get infected with sexually transmitted infections. And the only way to go around that, especially with young people, is if we can find ways of helping people abstinence. And in marriage, we talk about condoms. And then, of course, we have got those that are incurable. It's not just HIV, you've got your hepatitis B, you've got your herpes simplex, and you've got your papillomavirus and HIV. These are not curable. We just contain them. So there is value in us trying to find ways of dealing with this from prevention. I'm turning a little bit to talk about tuberculosis. These are the figures. In 2022, sorry, my other two is missing there. WHO, no, that was 2020, sorry. WHO recorded that we had 1.3 million people who died from tuberculosis worldwide. And out of this, 214,000 of them were HIV positive. And it has been found out that as of 2019 statistics, 30% of the people who died from HIV was actually due to tuberculosis. It is estimated that up to 64% of those with HIV are estimated to have TB. And up to 74% of those who have TB have HIV. And these numbers will vary from place to place, but this is the wide range. And the highest place where this prevalence and co-infection was found, it will be those numbers, 64% and 74%. Therefore, whatever programs we are coming up with, we are encouraging that those who test for HIV should be encouraged to go on to test for TB, and those that have got TB should be encouraged to go to test for HIV because of these numbers that we are sharing. Some of your countries like Nigeria, your highest mortality is actually coming from TB. as of 2019-2020, the highest killer was the single condition was TB in Nigeria. And if we are looking at these numbers where there's co-infection, it is very possible that if we were to ramp up HIV testing in Nigeria because of the high prevalence of TB, it's possible that the numbers would be higher than what is currently reported. Let's look at HPV, herpes papillomavirus, which I said causes cervical cancer. Globally, 5% of all cervical cancer is among people that have got HIV. However, in sub-Saharan Africa, where HIV is prevalent, this number is found to be above 40%. So 40% of people, more than 40% of people who live with HIV, according to 2020 publication of WHO, have cervical cancer. It is said that 85% of women with cervical cancer, they live in sub-Saharan Africa. So, although the world is reeling from cervical cancer, it is us here who have the problem. And this is found to be something that is co-infection with HIV. Therefore, there should be deliberate efforts to screen for cervical cancer for all those people that are coming in with HIV, especially in our facilities or in any places where we work. It will be very helpful. We need also to enhance HPV vaccine. The next two slides, I've taken them from the WHO websites where they're talking about HPV, cervical cancer, and HIV. And you can go and Google search and look at them yourself. But they have also set up global targets because of the big problem that cervical cancer is becoming for us. And we have got what we call the 90-70-90. By 2030, we would like that 90% of all the girls be fully vaccinated with HPV vaccine by the time they reach age 15 years. This is because HPV is the one that is causing HIV, and it is best prevented before somebody becomes becomes sexually active. It has been found out that when this vaccine is given to those people who are already sexually active, it doesn't work as well as it does when it is given to them when they're children. Therefore, generally, this vaccine is given for those that are between 9 and 14, and many countries have different campaigns for that. But from the WHO perspective, the target is to go to 90%. And then with the other one, 70%, we are saying 70% of women should be screened with a high performance test by the age of 35. And again, by the time they are 45, screened for what? For cervical cancer. And this is a very, very simple thing to do, which we can talk about in another presentation. But those who are health professionals on the forum would know that it is quite simple actually and very effective to do the screening. And then 90% of women identified with cervical cancer disease should be receiving treatment. We can discuss another time how far we are on this, but this is up to 2030. As you can see, these things are tied together. We have now the Global AIDS Strategy for people who are living with HIV over and above the ones of the 95 that you know for treatment. We are saying 90% of all the girls that have got HIV in priority countries, they should have access to HPV vaccine. Now, specific to those girls that have got the HIV. And we are saying women, 90% of women living with HIV, 90% of them should have access to integrated or linked services of HIV treatment and cervical cancer. As you can see, the world is pushing us to say, let's not just look at HIV alone. Let's look at it together. And I won't go into details with this, but these are some of the interventions and strategies. I put them in here so that when I share my presentation, you can be able to read them. Now, what can we do as Aaim? We have run in other divisions, maybe not so much in WAD, projects, and we are willing to work with you. This was actually done with SID, sorry for having SID there. To work with you to put together whatever projects can be useful for your places. We are looking for projects that are relevant to your local situation in any of the things that I've talked about. Those projects, then you can have your applications that will go through your union and then they'll be forwarded to WAD. Sorry there with the SID there. I am at SID now. So when I type, sometimes my finger slips to that. We will be having an application form from there that after our Rwanda meeting where we are going to be going for the advisory, those forms will be then shared. Those are the kinds of things they'll be asking for, that we need to know what it is that we are trying to do. How does that help you, the mission and your community? What do you expect to get out of that? Who will be the recipients of that? And what are the costs of that? And we will be able to see if this is something we can help you with. So some of the possible initiatives are stated there. I'm chasing time, so I won't be going too much in details, but you can have a project for a given time to say, for the next 1 year, I'll be doing this. We encourage you that your projects should not be more than 1 year, because your churches run on 1 year cycle. You will struggle to get the program moving from one director to another. We can assist you to start up income generating activities. That's what IGA they stand for. We can also work with you on capacity building initiatives. You may be having people who have been doing some things, but they are lacking capacity in some ways. So Aaim can work with you to see how we can possibly sponsor, if that's what is the need, or give ideas or facilitate for other people to come and help you to build more capacity for your initiatives. We can be able to assist you with a one-time off assistance to boost some initiative that you are having. We can also work with you on campaigns for specified causes. All of this is from the division to the union as coordinators working with your communities. The office of Aaim will be helping you through those structures. And all of those we as I said, within the given objectives as to the stated goals. So I've included some other information here because some of you may not be health professionals to understand that when we are talking about HIV preventions, these are some of the initiatives that can come through. And then winding up, let's just be mindful that even as we are talking to people about drugs and treatments, there can be complications. We do run some training sometimes on issues of drug reaction and resistance. And in Africa, we are finding out that we have also to deal with issues of HIV/ARV resistance. And I'm just putting this as something for us to be mindful of as we are talking about drugs and drugs. And lastly, I'm just putting up here some of the projects that Aaim has supported in other places. We have done the circumcision project in Kenya. I don't have time to talk much about that. Those of you who will be coming to Rwanda will have an opportunity to hear more about some of these projects. In Cameroon, they've had the Grandmothers Club, we have had sex workers deterrents, we have got orphanages. There are different projects that we can do with different people. And if you have people who are coming to Rwanda, you'll be able to hear more about this, which will give you ideas of what projects you can put yourselves. So, Pastor talked a bit about stigma. I just want to say to us, we as leaders, that's where the stigma and discrimination should start. We have to be the ones who must end the stigma. Because if me as a leader, I'm seen to come across as stigmatizing or discriminating, it may be very difficult for the people that I'm teaching with that. So I thought that I should just touch on that, because a number of issues that we are hearing are that sometimes our leaders are the ones that are dealing with the stigma and discrimination. And we have got a number of verses here just to help you where you are, to say, as a church, we stand against stigma and discrimination. And we stand against that because we know that the Bible does not condone it. Jesus came to die for all, according to John 3, verse 16. And we know that there is no person who is so sinful that God can touch. We know that because of Romans 3, verse 23. And we know that Jesus has taught us to love everyone and not discriminate. And that Jesus shown compassion for everyone, even those that had diseases that were discriminated at that point in time, like the lepers. I thought I should just share a number of those with you. My last slide, I want to say to us that as leaders, we need to take up this issue of HIV, sexual transmitted diseases, and all the things we've talking about seriously, because if we do not, and we ignore talking about these organs, sexual reproductive organs, we are going to end up with a problem where stigma and discrimination is rife in our churches. A situation where our youth have got wrong information because they'll get it from somewhere else if they don't get it from us. In our churches, no matter how much resistance you are getting, you need to stand up there and bring these things to the fore. We'll end up with a situation where we are having church members that are living with fear because they've got sexually transmitted infections and they're struggling with those diseases, but there's nobody to talk to. They will end up trying to go to those prophets and those witch doctors and the like because there's nobody who can tell them the information. This is a taboo topic. We need to break that taboo. Of course, we'll end up with families that are broken because this is so taboo. And ultimately, we will end up with death. So we would like us to talk about the prevention of all these things because prevention is not just better than the cure. I want to say to you that prevention truly is the cure for a number of our ills that we are having. God bless you and thank you very much for your attention.
Thank you very much, Doug, for such a powerful presentation. We are so excited for helping us, running us through what your office is doing and what you expect from us and what we also can do as Aaim coordinators in our various unions conferences as well as in our local churches. In fact, the presentation has sunk very deeper into our hearts, which will help us. It will serve as a springboard for our activities in the local churches. Thank you very much. Now the floor is open for questions and contributions. The floor is open. The doctor walked us through some of the projects Aaim is able to support. We saw them and what we are to do. The floor is open. If you find it difficult to raise up your hand, please, you can just ask the question or talk. Thank you.
Dr. Paul, good morning.
Good morning.
I'm Stephen from Ghana, precisely. I have origin, Tepa. Yeah, I want to know whether the slides will be shared because some of us, we didn't join the first presentation so that we can study it vividly so that whatever that is supposed to be done, we can have the info, put them together so that we can put something across to help the church members on this aspect.
Thank you very much. Yes, the slides will be shared on our page. We've created a page for Aaim, so it will be shared there. Thank you very much. Yeah.
Yeah, I've also posted there that I'll share my slides with the organizers and they will see how they share them further.
Yeah.
Just have to correct a few mistakes that I saw as I was going through. So I'll just to make sure that they don't come with that many mistakes, typos and the likes. Once I've cleaned them up, I'll share them with you, with your leadership.
That is okay, Doc. That is okay. Yes. Is there any other question? Okay, Joseph, Aka, Mesa, Joe.
Yeah, Doc, good morning, and we want to thank you and your team for that good work you are doing.
Thanks to God.
My humble submission is on how we, in our various conferences and local church can, help reduce the spread of HIV. We are all having a home and family institution in our local churches, and this is a place where every marriage before the pastors who join marriage, they go through counseling. Let us deepen that family department. It should not be a rubber stamp. Just the couples can we just introduce them. It should be part of our yearly home and family materials that we should encourage couples to go through the screening the HIV screening if they want to tie the knot. I believe this will also help reduce the spread of AIDS. Each partner will also know his or her status. Apart from that, the ministers at the various conferences who used to join marriage, we should not always wait till couples are coming for counseling. During car meetings, we should liaise with the health ministries department in various conferences, in our conferences, to pitch this AIDS campaign, the testing, how we can encourage our members to feel free, just go walk, just check their HIV status. I believe by doing so, number one is going to reduce, once you know your status, biblical way, we are preaching to abstain.
Oh, we've lost him.
I believe once we do our honest part in the local church and at the conference level, at the union level, by promoting, I believe we can also reduce the HIV spread. And that is my humble submission, sir.
Thank you very much, Doc. Do you want to speak to what his contribution?
No, thank you. I think it is it's fine because it's a recommendation. I'm understanding him to be saying they have premarital counseling. My only comment would be to find ways to empower those that are doing premarital counseling, because sometimes the challenge may be that the person who is doing the counseling may not be well equipped as to how to handle this. In other places, we have found challenges whereby somebody who's not trained on how to deal with people's health matters finds out that they counsel them to go for testing, and it turns out that one is positive, the other is negative, and they usually go back to the counselor, and they go back to the pastor to say, Pastor, what do we do now? She is positive and I'm negative, and the pastor has found himself at a loss. So that's why I'm saying we should try to find ways of supporting them in that regard. I like the idea of testing at camp meetings. It would be nice if we can be having the health professionals in charge of that, because the biggest challenge you have had in other places where testing is open is that people don't always know how to handle people's private matters. And sometimes it can be a shock when you are at a camp meeting or at a health expo and you find yourself HIV positive when you were just doing it for the fun of it, or doing it because everybody was doing it in terms of testing. So we need to make sure that if we are going to have test sites on otherwise public places, let there be people there who are equipped, trained preferably, to handle the aftermath. If somebody is so shocked that they don't know what to do, people can really react in very unexpected ways when they are hit with the shock of this kind of news.
Okay. Thank you very much, Doc, for adding your voice to the submission. Jeremiah Bella. Jeremiah, can you switch off or on your microphone? Jeremiah. Jeremiah,
hello.
Okay, yes, sir.
Okay, good morning.
Good morning.
A great presentation. I joined in quite late, so I didn't know if you've talked about the medication, the management of HIV. But I wanted you, if you can show a little bit more light on prophylaxis. I want to know if there is any prophylaxis out there for the public so that people can take, and if there are, what are the medications? Is my question clear?
Yes,
yes. Yeah, it is clear. Doc, can you respond?
Okay. Firstly, no, you didn't miss anything in that regard. We didn't touch on that because we're just looking at the programs. Secondly, medications, there are various things that are out there. We have what we call, most people are used to post-exposure prophylaxis. That's, or otherwise given abbreviation PEP. Post-exposure prophylaxis is when somebody is given some ARVs within 24 other places, they'll say 48 hours of exposure to a potential HIV situation. That might be somebody who has pricked themselves with a needle, trying to assist or working with somebody who has got HIV, or somebody who has had sexual relations with somebody and then they turn around and think, what if this person has HIV? In clinics, we see it a lot with the people who were intimate and they had a condom and the condom burst and he's suddenly scared. So all of those is post-exposure prophylaxis and is given maximum 48 hours after somebody has had exposure. The idea of that is to concentrate the drug within your body and hopefully help you not acquire the infection. Then we have what we call pre-exposure prophylaxis. Not all countries around the world have that, but there are some drugs that have been developed that many countries are allowing them slowly but surely, that people can take the medication if you are working in a high-risk area, or if your work life, in this case, I'm talking about like prostitutes and the like, that is their work life. If your work life is putting you in a high risk all the time, and of course, also we are talking about people who are discordant. That is one of the couples is positive, the other one is negative. Those are some of the people who would then go and take pre-exposure prophylaxis. And they start ARVs. They don't have HIV. They have tested negative, but they are living in an environment where they believe that they are perpetually under threat of getting the HIV. I don't know which countries in West Africa already have the medication rolled out. That's something that we'll need to look for information on. I'm aware of other countries, and different countries have different drug combinations. And drugs, once they're developed, they usually will have to be registered within a country for that specific thing. Sometimes you may find out that drugs may be available in country A, but they're not available in your country because maybe they were not registered to be utilized in there. Beyond that, there are a lot of advances that have been made on vaccines, but no, we do not have a vaccine for HIV right now that is readily available in the market. We are having some that are supposed to be at the final stage, and they keep promising that before 2025, we'll find the vaccines for that. But let us know that when that vaccine comes out, it will also take some time before it is rolled out. So in terms of the drug therapy, those are the areas that you can talk about on prevention. Otherwise, we are still talking about condoms. And from a church perspective, within a marriage setup, the church is not to be seen to be promoting extramarital, outside marriage relationship, sexual relationships. So from the church perspective, as leaders in the church, we talk of, yes, the use of condoms within the marriage setup. Thank you. I hope that answers your question, sir. You will let me know if you answered.
Thank you very much, Doc.
Thank you.
Okay, let's come to Kwaku Badu. Kwaku.
Thank you, Doc. Please, during the presentation, Doc talked of project. I want to find out when application will be open for proposal, and my second and the areas of interest for the project. Then I also suggest if a platform can be created so that those of us who have interest, we can join, then we share ideas. Thank you.
Okay. Because we have restructured a lot of things in Aaim, we have decided that we need to be together to launch this. Therefore, when we are going for the Aaim advisory from the 12th to the 15th of April in Rwanda, that is the point where we will unpack everything around the projects. There were people who were already sending projects proposals now, but I realized that we might have confusion when other people are saying, but this, but that. So we will put our heads all together. And after that, after the April meeting, that's when we are going to open. So for all intents and purposes, I believe that by the 1st of May this year, projects then will start rolling, because by that time, everything that we would like to put in place, we expect that to be in place, and your leaders will be in Rwanda, and we will all have an opportunity to talk openly about the suggestions and the recommendations that are being made and see what may work and may not work. The platform of where that can be discussed will be in the hands of your able leaders at your division level and union level. Each division, I believe, will make their own practicalities of how they will implement this once we have agreed on the global. What I can only say is that, as I've stated in my presentation, whatever projects we are going to be running between now and the next year, June, which is the time that this quinquennium ends for the General Conference, they will need to be in line with the things that we have talked about, adding value to the I will go, but at the same time, chasing the 2020, 2030, 2025, all these things that we are talking about in the United Nations. And WHO and all the other big bodies, because that's what our countries are all interested in. And truly speaking, that's really where we are all going. Having said that, we are looking at a system whereby we will be able to equitably distribute the little funding. By the way, it's not a pot of money that we have. The little bit of funding that we have, to equitably distribute it between divisions, and the divisions will figure out how they deal with their equity for their unions. We also want to equitably distribute between awareness, prevention, care, and support programs. We don't want all the money to go into care and support, or all the money to go into prevention. We need to equitably distribute somehow in those areas, because in so doing, all churches can have an opportunity. But if we distribute them weighing it towards one direction, we may leave others out. They have wanted to participate. I hope that helps you understand how we are getting through this. Thank you.
Thank you very much, Doc. We will take Pastor Prince. Pastor Prince Obed, Cyril. Pastor Prince, are you around? Pastor Prince, okay. Thank you very much, Doc. I think we...
All right, so good morning, all of us.
Good morning.
Yes, now, my question is this. The challenge that the church stands to face has to do with stigmatization.
Mm-hmm.
Because already, even within the church, if somebody should know that you have found yourself in an awkward way, or something that we deem unacceptable, the way we begin to react towards the person, our behavior, our attitude, our mannerisms. So how do we handle this issue of stigmatization in the church? Thank you.
Okay, thank you very much. Doc, can you add your voice?
Yeah, this time is to really add the voice. When a pastor asks you, how do I handle something in the church, and I'm not a pastor, it becomes very challenging, pastor. Anyway, I believe that this issue of stigmatization is driven by various things. Some of the slides that I quickly ran through as I was chasing time were methods of stigmatization. There are many, many ways that we do stigmatization without realizing that. For instance, if I were to ask any of the pastors here how ready they will be to baptize somebody knowing that the person is HIV, baptism as in being in the same pool with the person. Now, the issue around that then goes around information. Can HIV be spread by being in the same swimming pool with somebody? And the answer is no. Now, if the pastor and the person begin to know that, then the level of stigma will go down. In other words, educating people on various ways that HIV is spread and is not spread is the starting point. That's how we can reduce that. Because a lot of times stigma is driven by ignorance and fear. If we can get the stories, remember I said, I recommended that you guys start collecting your stories out there. If we can get more testimonies and more stories of people who are living with HIV or affected by HIV, able to share them, they will begin to dispel the myths around this. The second point I would like to make is, as Aaim coordinators, we would like to encourage you to deliberately target these 4 departments. Ministerial. We are finding out that a lot of resistance to HIV work and even information dissemination that could help us with stigma and the like is driven by, unfortunately, our pastors in many places, and I'm talking across the continent. I have not worked closely with WAD, but I'm inclined to imagine you have the same challenges as ECD and SID have. So we need to get close to ministerial. We need to find strategic and deliberate ways of informing and empowering our pastors, because the pastor is the shepherd of the church. And if the pastor is well informed, they can help the folks to begin to understand things better. The second department you want to work with is youth ministries. The HIV is ravaging the youth department, and the youth are the people who are very trigger happy with their social media, and most of the time they start up and they help in spreading a lot of information that's not very helpful. If we can have our youth to be helped to understand and to come around, we will go somewhere. The third department is education. The education department is the place where people who are trained to teach and how to help us learn when we are being taught. And at the same time, that's the place where people are gathered together and accept information to be coming from there. Last but not least is women ministries. Women ministries and their Aaim, they are the people who more often than not are responsible for many stories running around. Apart from them being the highest affected and with infections and the like, which means we have to work with them. But they are, if you want anything to run fast, tell it to a woman. If we can get our women's ministry to begin to understand HIV and understand the dangers and the damage that's being done by a lot of the stories we run around, I think we can go somewhere. That's the best I can do at this point, Pastor. I hope that helps. It's probably not the whole answer. There are a lot more people who probably can add.
Thank you very much. Doc, you are 100% right. So my able pastor, the best is to educate the people. So wherever we will find ourselves, let us take at least a minute or two of our time educating them, for them to appreciate that HIV is not the end of life. It can happen to or affect any one of us. So, and it is not true, as we all know scientifically, that those who have contracted the disease, not all of them had it as a result of sexual activities. So please, it can happen to any one of us. Clinical accident can even lead to HIV. So please, we should be able to appreciate some of these things. Thank you very much. It's good you've asked. Even if Doctor has time, she will tell us, even in some places. Please, you are Please, please, you're disturbing us. Please, switch off your microphone. Okay, so if doctor has time, she would have given us this information. Even in some places, those with HIV, they don't even allow them even to officiate in some of the churches, and it is not right. So please, we should be able to speak against some of these things. The best is to educate our people. Thank you very much. So, Doc, I think our participants, we want to thank you very much for.
You have three more hands. Are you taking them, or time is gone?
I've not seen them, please.
I can see three hands.
Yes, Dr. Randolph. Dr. Du, the medical director of SD Hospital, Kwadasho, Ghana. Doc.
Thank you, Director, for the opportunity, for being part of this wonderful presentation and the learning experience. Director, from the lectures that we have received today, and we've been encouraged to accept the reality and deal with it as it is. Now, coming to about prevention of HIV among the youth, who are the highest risk, and the condom use is one major initiative for prevention HIV. However, it appears to me that the church somehow either is silent or is not very willing to push from that end when it comes to among the youth who are not married, i.e. premarital sex, which the church does not encourage. Of course, the church preaches and teaches abstinence. But we've been asked to accept the reality. And the reality is that we all know that majority of our youth are engaged in sexual activities. Therefore, is it not a disservice to us that we, after we've done all the education, the teaching, the preaching, and everything, encouraging them to abstain, if they are not able to abstain, and we are not also encouraging them to use the condom, then when they go, they will definitely attract this disease. How do we deal with that situation? My second question is, maybe it's a comment. I wanted to find out if GC has any plans, for example, knowing that the shortages and sometimes non-availability of antiretroviral drugs, if GC has any plans, for example, maybe providing these drugs so that we can serve church members and our clients who test positive. Thank you.
Thank you very much, Doc.
Let me start with the last one, because it's the easiest of them all.
Okay.
No, GC does not have any plans or even a budget for that. I think it's a very sad one, unfortunate, but it's the truth. I can't sugarcoat it. The General Conference then doesn't actually run our facilities, as you know. Our facilities be under the entities where they are. I understand you are in Ghana. I imagine that your hospital will be under the Ghana Union or else under the West Africa Division, however you guys are structured on that side. The closest that the church comes to supporting will be with the AHI, that which I believe the doctor that was speaking would know about, the Adventist Health International. And we are trying to work with AHI as Aaim, and they will be coming to Rwanda, by the way, trying to see how we can be practical, because we know that AHI has sometimes come through and helped with sometimes equipment and other things. But we are also cognizant of the fact that we can't commit the General Conference to all the hospitals around the world. It's just simply not feasible or doable. So those are the realities that we are working with. So your short answer at this point would be, no, we don't have the plans or budget to provide any ARVs. Even with Aaim, we don't have that. The next question on the issue of condoms. I will just like to answer it with a question, and please take it in the context and the spirit that it is given. The church, when we talk about the principles of the church and the philosophy, we stand on the Bible. We know we are fallen human beings. We know that the Bible calls us up to standards that often we are finding very hard to live up to. But even as we are unable to live up to those standards, we still must stand on our principle. The issue of sexual relations is no different from all the other issues that are called for by the commandments. Just because we are failing to keep the Sabbath is not an excuse for us to say our young people are currently unemployed, which is the truth, by the way. Across the world, young people are struggling with unemployment, and Adventist young people more so. And one of the reasons they'll come and tell you we are unemployed because we will not work on Sabbath. So my question that I said, I might have to answer your question with a question. Should the church then say, this is our reality, that as long as our young people keep the Sabbath, they cannot be employed, therefore we give them a dispensation? The answer is no, because it is not us who came up with the rule to say, thou shalt keep the Sabbath holy. It's not us. And therefore, we cannot take away that dispensation. By the same token, it is not the individual or the church that came up with saying that sexual purity must be maintained. It is not the church as an individual that had said that adultery and fornication are sins, and that have said that it is a breakage of the commandment of God to have sexual relations outside a marriage that was constituted and blessed by God. It's not a rule of the Seventh-day Adventist Church. It is a biblical principle. And therefore, it is not for the church to say, because our reality is that our young people cannot live up to the standards that the Bible has set, therefore we lower the standards. Yes, the information that will be out there will be saying, maybe you can use condom, you can do other things. But as a church, telling a young person to go and use a condom to prevent a disease, whilst allowing them to break the commandments of God by having sexual relations outside marriage, is to go against the principle that define who we are. We know that it is a reality. It is a reality that people break the Sabbath. But we are not going to go as the church and say, well, because of this, let's do that. So this is my answer to you, my leader. It's not out of being irresponsible that we are saying young people should be using condoms. We believe that the most responsible thing will be to try to understand what is it that is driving our young people to have sexual relations before marriage. How can we then come up with ways of helping them to not have sexual relations? Because we know that even with a condom, the heartbreak that comes from those sexual relations, we still have them. The suicides that come out of those sexual relations, we still have them. There are a lot more things that come out. Other sexual relations are not necessarily the ones that can be prevented by a condom. A condom does not prevent everything that's transmissible in sexual relations, including a heartache. Why don't we then put our energy into trying to understand the other side? That is our position. That's all I can say, my leaders.
Thank you very much, Doc. We will take the last person, please. We are to end before 12 o'clock, and we have 9 minutes. So, please, we are Faye Achampong. Is Achampong?
Yes, Doctor.
Please, you have a minute to ask your question.
Look, I'm also really appreciative for such a thought-provoking presentation. I want to speak. Some of my issues has been spoken about by Dr. Randolph, but I wanted to suggest that concerning the issues of adolescents engaging in illicit sexual practices, the church can also capitalize on usual a presentation that is sent to us by WAT, especially during health and temperance weeks. And I think we can have a uniform platform. So we can also bring engage our HIV specialists to make a presentation that can be used or utilized during that time. So we can have a uniform platform. I'm saying this with regards to evolving issues with HIV, because HIV issue, their medications keep on changing day in, day out. So having a common platform from the specialists, I think will do us well. Thank you very much.
Thank you very much.
Yeah, that's a very good, a very good point. And I think also maybe to add on that, so that as we are thinking about this, to put it together, it will probably go a long way, Pastor Paul, if we as a church would also deliberately begin to teach people about the dangers of indulgence in sexual relations. Because part of our problem, why we believe that young people all they want is a condom, is because perhaps we are not deliberately delivering uniform messaging out there, you know, about all the other challenges and other things that are involved in sexual relations. Maybe we only talk about sexual transmitted infections, but a sexual relation is much, much bigger than sexual transmitted infections. So I do agree that we should get the professionals. We have got our psychologists, we have got our people, and we do have, even from the World Health Organization, issues that are being shown about other complications, like people later not able to have children, like people being hurt in their sexual organs. All those things are issues that are not talked about. We are only following what the world is showing, how sex is nice, and our children are going there, and we are trying to help them enjoy it by giving them the condoms. So maybe I agree entirely. We will, by the way, be launching a very, very vibrant prevention campaign in Rwanda, which out of this we hope it can be taken up, which is being developed by the young people now across the other divisions, to try to see how can we get across to our young people on issues of sexuality, focusing on prevention and chastity, and not just prevention of infections.
Thank you very much, Doc. Please, you'd like to bring our presentations to an end. Thank you all, our participants, for sparing us some of your time. We believe very soon we will meet again. Let me take this opportunity to give you the following pieces of information. Number one, just as Doctor was saying, the month of April, we are having our advisory, HIV Aaim advisory in Rwanda. So we've invited our medical directors, HIV coordinators and our health ministry directors from the local conference level hospitals to attend. We've already shared the quota. We've already shared the quota with our various unions. So now we are working on the compilations, which will be sent to Doctor very soon. Again, by the grace of God, in the month of September 17th to 22nd, we'll be having Health Ministries Congress in Ghana at Valley View. So please let us prepare. We are all attending. And during that time, Dr. Sikwa also will be attending. We've invited a lot of people, including General Conference, Health Ministry Director, and other dignitaries. Once again, I'm happy to inform you that we have in our midst Professor Daniel Ganu, the professor of public health at Adventist University of Africa, Kenya, is in our midst. Doc, you are welcome. Thank you very much for your time and your support. Thank you very much. Yes, we thank all of you for participating. Very soon.
Please, hello, please, can you take the first item in April?
Yes.
Again.
Yes. April, we have HIV Congress. Advisory in Rwanda. And we've already shared the quota with the unions. We are inviting our Aaim coordinators from the unions and also our churches, as well as our hospitals where we have HIV programs. So we've already worked on it. Kindly take note of this. Thank you very much. Doctor, would you like to throw more light on the Congress?
Yes, actually, that's why I was raising my hand to say, I hear you counting the people and you are not counting educational institution. You had a quota of up to 3 from the educational institution. As I said earlier, that there are some departments we are targeting. Can we, especially your universities, if we can have 3 of them, your seminaries or whatever, because we believe that some of our challenges are coming from the pastors. And if we can get those who are training pastors to be on the same wavelength. Secondly, the issue of the advisory, people who don't work with the church usually struggle to understand what an advisory is. It's something like a convention. You are right to call it as a convention. It's a convention where we get all the people from the highest level, like in this case, from the General Conference. We'll have people from the Presidential General Conference and the whole Health Ministries Department of General Conference. And then we have a number of our leaders. We have, I think some of your officers are coming, ECD officers. They come together so that we together map a way forward on a particular critical area. And in this case, you who are able to come will have an opportunity to hear firsthand what are the issues and what are the plans and where are we trying to go, hearing them from the office of the president, from the General Conference, and from your division leaders and from all the people that have got to deal with the issue of HIV and AIDS. So we get a number of presenters who are presenting from different places and different things. And out of that, we come up with some resolutions and plans that will be expected all of us to keep up to. So by the end of the quinquennium, we'll be looking back to say, what have you managed? Usually this happens at the beginning of the quinquennium, but I came into the office in the middle. That's why we are doing this advisory now. But then after the next, when the next quinquennium begins, the new directors who come in will get there. That's where we get all our marching orders, or we realign ourselves to say where we are going. Thank you.
Thank you very much, Doctor, for the explanation, and also throw more light on this. The youth, the women ministries, and education at the division level, we are working on it, and we strongly believe they will be there joining the program, so that they will disseminate the information to our institutions and also to the youth as well as our women. Thank you very much, and may God bless you. Please, may God bless all of you. Doc, may God bless you for such a wonderful and timely presentation. In fact, you've whet our appetite. So to position us is at the right place to promote the activities of the game. Thank you very much, and may God bless you. At this time, you invite Pastor Professor Daniel Genu to pray.
Amen. Let us go for prayer. Heavenly Father, we cannot thank you enough for the grace and the mercies you have always shown. We thank you for this webinar. We thank you for the blessings. Many ideas have been shared. We pray that you will bless all our deliberations, and as we move forward, give us foresight, give us vision to help us live godly life so that your name can be glorified and your name can be honored. As we separate from each other, may we not separate from your presence. May the Holy Spirit continue to direct us. May we be a source of blessings to all those we are working with. We thank you for your blessings, for we ask in Jesus' name. Amen.
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 Amen. Thank you very much.
Amen.
Amen. So what do we say to Dr. Sita?
Amen.
Amen.
Merci beaucoup pour la traduction.
Bonne présentation. Merci beaucoup.
Amen. Ça nous a beaucoup aidé.
Merci pour la traduction. Merci pour la traduction.
Hi.